Hi there, welcome and thank you for joining us today for the launch of Action for Global Health's new 2022 to 2025 strategy. My name's Katie Husselby. I'm the Network Manager for Action for Global Health. I have blonde hair and today I'm wearing a blue jumper with pink hearts on it. Just in terms of some housekeeping to start us off, you should be able to see Russell, our British Sign Language interpreter, pinned onto the screen. We also have translation available in French and Spanish for this webinar. If you go to the bottom tab, you'll see an interpretation, a little globe sign. If you click on that, you can choose to listen in French or Spanish. We're hugely excited to be sharing our new strategy and approaches with you all after more than a year in development. We're going to be using the next hour to highlight some of the exciting changes and ambitions that we'll be implementing over the next 4 years. I'm thrilled to be joined today by a number of speakers who will be presenting our new strategic direction, including Dr. Peprah from Youth Transforming Africa, Kristine Yakhama, the coordinator of Good Health Community Programs, and General Coordinator of the African Diabetes and Hypertension Association Kenya, and Dr. Helena Davies, Direct Stakeholder Trustee for the Worldwide Hospice and Palliative Care Alliance. Ellen, Kristine, and Helena have played critical roles in the development of our strategy over the past year, advising us and feeding into our strategy development through our key stakeholder advisory group. So I'm delighted that they're here to present the new strategy with us today. You'll also be hearing from Harry Rogers from Results UK, representing the Action for Global Health Steering Committee and the Action for Global Health team, including Melanie Scagliarini, our Advocacy Officer, Melissa Jones, our Digital Campaigns and Communications Officer, and Yuri Langelind, our Senior Trust and Foundations Officer. Whilst there won't be an opportunity for live Q&A today, we really encourage you to introduce yourselves, pop your questions, comments into the Q&A box, and we'll try to answer them in the Q&A box as the webinar is going on. We'll also be hosting an informal drop-in session in a few weeks' time. So if you'd like to come along to meet us, ask questions and discuss the new strategy and ways you can get involved in more detail, then we'll be sharing the details of that drop-in session soon. You'll be able to find the link to our full strategy document in the chat box now, so please do read at your own leisure after this webinar. Please note that the full document is currently only available in English, but summary versions of the strategy will be available later this week in French, Spanish, Arabic, and Portuguese. We're also recording this webinar, and the English, French, and Spanish channels of the webinar will be made publicly available on our YouTube channel. Finally, I'd like to take this opportunity to thank some of the people who've been really actively involved in helping us to get to this point. Our key stakeholder advisory group, the Action for Global Health team, our steering committee, and our fantastic members, funders, partners, and our host organisation, Stop AIDS. I'd also like to express our gratitude to our consultants, Yasmin and McCall from Q3 Consultancy and Lizenia Weeks Richmond, for really helping us to guide us through this process. It's now time to dive into the new strategy. So I'm delighted to hand over to Kristine, Helena, Ellen, and the Action for Global Health team, who will be presenting our new 2022 to 2025 strategy. Kristine, I'd like to invite you to now visually describe yourself before beginning the presentation. Kristine, over to you.
Thank you, Katie. Good morning, good evening, good afternoon. My name is Kristine Yakhama. I'm going to present to you about the Action for Global Health Strategy 2022-2025. I'll begin by saying Action for Global Health is an influential membership network convening more than 50 organizations working in global health. We provide access to key decision makers, joint advocacy, and campaigning opportunities, and the chance to participate in an active global health community to drive progress towards Sustainable Development Goal number 3, that is good health and well-being. Kindly share the next slide. Our vision, we envision a world where health equity is achieved and everyone has access to the quality healthcare they need without being forced into financial hardship. Our mission, we harness the expertise and strength of our members and partners, including people with lived experience of health inequity, globally, and civil societies, organizations based in low and middle income countries to secure political action and commitments in the UK to improve health equity globally. Our strategic goal in 2025, strengthened actions and commitments from the UK government have positively contributed towards achieving health equity, resulting in more people accessing quality, affordable healthcare tailored to their specific health and well needs. Next slide. What we mean by defining the health equity. Individuals have parity in health outcomes. People facing disadvantage because of their specific characteristics, including age, gender, ethnicity, disability, sexual orientation, gender identity, gender expression, and sex characteristics, and or their social, economic, demographic, or geographic standing have access to quality, affordable healthcare services tailored to their specific health and well-being needs. Next slide. Measures of health unequally distributed. We have the health status. Here we are talking about case study examples. We have cancer and stroke, and then access to care, quality and experience of care in the health facilities, behavioral changes, and social determinants of health. Here we are talking about poverty, unemployment, education, and water. Between people and groups based on experiences. We are talking about geography, that is the e.g. the region or country, whether rural or urban. The socioeconomic status, here we are talking about income and employment. Specific characteristics, here we are talking about age, gender, ethnicity, sexual orientation, gender identity, gender expression, and characteristics. Socially excluded groups, here we are talking people experiencing homelessness, nomadic populations, people affected with conflict, internally and externally displaced people. Next slide. Our health equity principle, we have health as a human right. We believe in the fundamental right to the highest attainable standards of physical, mental, and social health and well-being, as well as healthcare for all without distinction on the grounds of race, religion, political belief, sexuality, disability, economic, or social condition. Here I'll give an example whereby we have a Constitution, Article 43, that says every person has a right to health, especially sexual reproductive health. 2, we are centering the voices and experiences of people living with or communities affected by health inequities. We believe people with lived experience of health inequities are experts, and we will actively solicit meaningful input from members within our community and support them to authentically tell their stories in a and respectful manner in all of our work. Here, I'll give an example of people living with experiences. We are talking about people living with HIV, people with tuberculosis, and on meaningful engagement, we will extend global for AfGH membership to low middle income countries based organization and UK diaspora groups, and work with them to highlight health inequities and propose solutions to the UK government. Next slide. I take this opportunity to welcome Dr. Helen.
Thank you, Kristine. I'm Helena Davies, and I'm wearing a black dress with white crosses on, and I've got my hair in. We've already heard from Kristine that we're going to broaden our focus as part of the AfGH strategy. And as we develop the strategy, our discussions around geographical inequity led us to reflect on AfGH's historical focus, solely on low and middle income countries. We recognise that health inequities are actually not specific to low and middle income countries, and the COVID-19 pandemic in particular has brought sharply into focus how health inequities are also pervasive in high income countries, including the UK. For example, excess mortality from COVID was significantly greater in those with pre-existing comorbidities than the general population. And furthermore, these comorbidities are much more prevalent in lower socioeconomic groups and other disadvantaged groups, such as refugees. And just to highlight examples of other inequities in the UK socioeconomic status is critical. Between 2017 and 19, males in the least deprived 10% of areas in England could expect to live 83.5 years, almost a decade longer than males in the 10% most deprived areas, with a life expectancy of only 74 years. The gap in healthy life expectancy between most and least deprived areas is even greater, almost 2 decades. Not only do people living in the most deprived areas have the shortest lifespans, they also live more years in poor health, with an average of nearly 2 decades longer living with poor health compared to their wealthy counterparts. And in addition, specific population groups have significantly shorter life expectancy than the general population. For example, men and women who are homeless at or around the time of their death live 31 and 38 years fewer than the average, respectively, while individuals with learning disabilities also have shorter lives than the average by 23 years among men and 27 years among women. Recognising that as the network shifts our focus to health equity, there is a need to give attention to health inequities in high-income countries, as well as low and middle-income countries, where the network has historically focused. We need to decide where to initially focus our efforts. Given our mission and UK focus, we will begin by broadening our attention to include health inequities in the UK, as well as low and middle income countries. Lessons learned will hopefully be transferable to other high income countries in the future. This major shift in how the network operates, the type of stakeholders it engages, and the health issues it addresses will require initial scoping, a gradual step change process, continual learning, including by the meaningful engagement of people with lived experience of health inequity in high income countries, and need regular review. We see this as happening over the course of the new strategy rather than overnight. In addition to broadening our remit to include high-income countries, AfGH will be seeking ways to diversify our network, and Kristine alluded to this already. In order to achieve this, we need to consider both who we are additionally going to include and how we are going to facilitate this. In terms of opening up our membership, there are 4 key groups we hope to extend our membership to: low and middle income country-based organisations and people with lived experience of health inequity in LMICs, individual country office staff based in LMICs, regional health networks, and UK diaspora organisations. In terms of the low and middle income based organisations, whilst the AfGH will retain its focus on the UK government and its links with it, there are a number of LMIC based organisations that we could make membership available to, including civil society organisations, people in low and middle income countries with lived experience of health inequity, disability organisations, health advocacy or communication organisations or networks, and finally, because given the importance of research, universities and research institutions, or even private sector development consultancies based in LMICs. As well as the LMIC-based organisations, individual country office staff based in LMICs are likely to have a valuable contribution to make. The current UK-based international organisations within AfGH often have low and middle income country officers and or regional officers who implement public health programmes, undertake or support advocacy and policy influencing, and/or support civil society action at national and local levels. Country officers and their staff are close to the health issues which AfGH advocates on. As appropriate, country office staff will be offered the opportunity to join the network under their organisational umbrella and contribute according to their interests and strengths. For example, a programme manager in a country office could provide statistics, case studies, or potential solutions for their country context to feed into AfGH's policy documents or participate in an AfGH working group. As well as local organisations and their staff, regional health networks are also important potential members, and AfGH will proactively reach out to extend membership or partnership with regional health networks whose visions are aligned to AfGH or who are working towards the attainment of the Strategic Development Goal 3 focused on health, particularly SDG 3.4, which aims to reduce NCD mortality by a third by 2030, and SDG 3.8, which focuses on universal health coverage for all without financial hardship. Regional health networks can represent civil society organisations from countries in their region, bringing vital knowledge and expertise to the network, including insights on trends within their regions. And finally, we will hope to engage UK diaspora organisations, which have the benefit of being a powerful network of individuals with close connections with low and middle income countries while living in a high income country. Next slide, please. It's not just about who we're going to invite to create an expanded membership. It's about how we're going to facilitate this and monitor the broader membership. We're going to operate with a two-way collaboration. Extending membership to the groups that we've discussed will ensure the voices of people experiencing health inequities in LMICs are at the forefront of AfGH's work. Careful consideration and transparency about what we can offer and how the network can support and benefit the member organisation is essential to making this an effective two-way collaboration. We will implement membership reviews to allow reflection on how to further adapt the network's processes to ensure meaningful engagement and maximal participation of new members. In recognition of historical and current inequity in resource distribution, and to avoid barriers to membership, a fee waiver will be put in place for LMIC-based organisations and UK diaspora groups, obviously except for private development consultancies. And finally, increased representation. We will also highlight the potential advantages of becoming a member of AfGH, which include access to key UK stakeholders and opportunities to participate in events which can support an individual's career progression. AfGH will give preference to lower middle income country-based and/or UK diaspora organisations to participate, attend and speak at key events, representing their organisation and the network, thus raising their profile and influence within the global health space. It is particularly important, as highlighted earlier, that this includes meaningful engagement at all these levels of individuals with lived experience. So having quickly led you through our shift to include high-income countries in our strategy, and as well as discussing changes in membership and governance, I'd like to hand over to Ellen to discuss health inequity and health system strengthening in the UK. Thank you.
All right, thank you, Helena. My name is Ellen Peprah. I have black curly hair and I'm wearing a blue dress. So this slide is giving us a snapshot of AfGH's strategic priorities moving forward. And the first I'll talk about is the UK's commitment to global health equity. Now we know that the pandemic has underscored the need for international collaboration in health and development for the achievement of the SDGs. The UK government, as one of the largest donors to global health, has now more than ever an important role to play in addressing health inequities in the UK, like Helena mentioned, and collaborating with other countries to reach their health-related goals. Recognizing the notable changes to the UK's development sector through the merger of the Foreign and Commonwealth Office and the Department for International Development, and the significant reductions in the UK's official development assistance, we will need to redouble our advocacy. In light of this, AfGH will continue to focus on the UK's role in achieving UHC globally, but with an enhanced and sharpened focus on ensuring UK political, financial, and programmatic commitments that will contribute to improved health equity globally. AfGH would also build on the strong relationships and multiple channels for engagement that has been established with the FCDO and parliamentarians over the period of the last strategy, and will continue to act as a common platform for members to unify their voices and influence the UK government. The next I'll speak about is the UK and health system strengthening. Focusing on health system strengthening will ensure that countries have the capability to address, prepare for, prevent, detect, and respond to epidemics and pandemics, disease outbreaks, and impending health threats like the antimicrobial resistance. Action for Global Health will advocate for health system strengthening as a core approach in the UK's work towards achieving health equity and UHC, building on the FCDO's health system strengthening position paper. Where appropriate, AfGH will ground its work on health system strengthening in the WHO's framework, as well as further explore decolonization of health system strengthening, look out for opportunities to integrate health system strengthening with the COVID-19 response globally, seek out avenues for increased resources for the meaningful engagement of people with lived experience, and also find out ways to engage civil society and communities in low and middle income countries in health governance and leadership. My colleague Kristine will take us through the other priorities. Kristine, if you can hear me.
Next slide, please. On the strategic priorities, here we are talking about the UK commitments to global health equity, UK and health systems strengthening globally, and then we are also looking at the UK change and healthcare, UK and the social determinants of global health. Next slide. On strategic approaches, next slide, please. The strategic approaches that we are going to use, we are going to develop evidence-based positions, member and partner engagements, influencing key UK decision makers, mobilizing public, parliamentary, and media influence. Next slide, please.
Hey, Kristine, sorry, that's the last slide for this section.
So I believe I need to take you through the action for global health inequalities and climate change. Here, I need to say that the life of every child born today will be profoundly affected by climate change. A child born today will experience a world that is more 4 degrees warmer than the pre-industrial average, with climate change impacting human health from infancy and adolescence to adulthood and old age. Without accelerated intervention, this new era will come to define the health of people worldwide and every stage of their lives. On climate change, it represents the greatest threat to global health of the 21st century, and it has threatened to undermine decades of gains in development and global health. Looking at the COVID-19 pandemic, which demonstrated the scale of catastrophe impacts that arose from international health threats, recovery from the pandemic provides us with a unique opportunity to shape more sustainable societies and strengthen health systems. These changes will protect the health of people around the world for generations to come. The health consequences that will result from inaction on climate change will have a disastrous impact on the most marginalized around the world. The communities that have contributed least to the climate crisis are also the most vulnerable to the impacts of climate change, worsening health and social inequalities, and shifting the goal of leaving no one behind further out of reach. And failure to act on the climate change will severely jeopardize the realization of universal health coverage in various ways, including by compounding the existing burden of diseases on severely stretched health services and exacerbating the barriers to accessing health services at the times when they are most desperately needed. The negative impact of health due to climate change already has spanned all world regions with population unaffected. However, low and middle income countries experience higher exposure to some risks while having access to dramatically lower resources to protect themselves, which has resulted in heightened levels of vulnerability. Conversely, whilst low middle income countries face the most dire consequences, it is the high and upper middle income countries that emit 86% of global carbon emissions, a major cause of climate change centuries of colonization, which has been followed by a high inequitable global economic system, having accelerated environmental degradation theory, extraction and deforestation coupled with racial oppression and gender injustice at severe and enduring cost to human and planetary health. This inequity and injustice has underpinned the root causes impacts of climate change on global health while corporate other vested interests or present formidable barriers to progressive policy making. I'll just share about the impacts of the climate change on health inequities. Here, it has been strongly influenced by individual and population factors, including age, gender, income, and prior health status. Older people and children are less able to respond and protect themselves from immediate hazards, while older people, especially those living with pre-existing health conditions, are especially vulnerable to the health impacts of the heat. I'll give an example during the drought when women and children in the low middle income countries are the most affected as a consequences of the gender-based roles and subsequent tasks in household decision making, such as going to the rivers to collect water. And then the housing, looking at the housing, which leaves them more exposed to the impacts of heat, flooding, storms, and airborne diseases from those in often high salaried office jobs, which is further compounded by access to health services, especially sexual reproductive health rights in women, the LGBTQ, negative maternal health outcomes, and increased prevalence of gender-based violence. The lack of access to sexual reproductive health rights services, which in turn negatively impacts family planning, safe abortion, and STI outcomes. How are we going to address respond to climate change? We need to adopt and strengthen health systems and broader infrastructure to build climate resilience, ensuring that health care can still be provided during climate crisis and to account. The impacts of climate change on UHC is also evident at the systems, particularly within the health services and provision of UHC eroding progress towards its three dimension, that is the coverage of the people in need of care, cost of treatment, and the care services available. I'll now share about the UK and social determinants of health. On the social determinants of health, we have put them in 5 broad categories. That is, 1, we have healthcare. A person's access to healthcare and its quality factors should include access to primary healthcare, health insurance coverage, and health literacy. 2, we need to look at the economic stability. Here we are looking at a person's finance and their health. We are talking about poverty, employment, food security, and housing stability. 3, we are looking also at education, a person's access to education and its quality on their health. Here we are looking at secondary education, language and literacy, childhood development. 4, we are looking at the social and community life. Here we are looking at the civic participation, discrimination, conditions within our workplace. And 5, we are looking at the neighborhood, quality of housing, transportation, water quality, and access to healthy food. I now hand it over back to Katie.
Thanks, Kristine. I'm going to pass on to Melanie.
Hello, everybody. So I'm Melanie. I am white woman, curly, dark, quite unruly, messy hair, quite frankly, black top on. I shall introduce the first 2 points on the left of this slide, covering AfGH's strategic approaches, before handing over to my colleague Melissa, who will tackle the latter half of this slide. So in terms of the first one, developing evidence-based positions, building our work on evidence has been a vital component to our work for some time. So moving forward, we will continue to expand and to build and then expand on this by identifying cross-cutting health equity issues within our strategic priorities. And this will enable us to develop evidence-based reports, briefings, and positions within our membership as well. This approach is really critical in many ways, but particularly 2. One is around building consensus within our network on core policy issues. The second kind of critical approach or reason for this approach is about grounding our advocacy in the broad lens and case studies from our membership. And this is particularly around embedded evidence and testimony of people with lived experience. In terms of the second strategic approach, influencing key UK decision makers. As previously, AfGH's influencing has been focused on UK decision makers. Moving forward, we will continue to build on this and leverage the strength of our really diverse membership and continue developing those strong relationships and building our credibility with the UK government. This is all in order to influence the UK's actions and commitments to health equity. It's important to note that we do recognise that the shifts in our vision and strategic priorities, particularly in relation to social determinants that was just spoken about a few moments ago, this will require engagement with new stakeholders across the UK government, particularly as our advocacy is expanding to include a little of UK domestic policy and its impact on health equity as well. So this will be taken into account as we move forward and we implement the strategic approaches here. Now I'll hand over to my colleague Melissa, who will speak on the final 2 points on this slide.
Good afternoon, everybody. My name is Melissa Jones and I am the Digital Comms and Campaigns Officer for AfGH. I've got blonde hair tied back and I'm wearing a black polo neck jumper with hooped earrings. So for the last 2 approaches that I was going to run through for everybody, the third one is mobilising public and parliamentary and media influence. We're going to continue to build our Healthy Futures movement, widening our reach and engagement with the UK public, as this is our public-facing campaign that we run to increase political pressure to act on our strategic priorities. We will achieve these through deepening our collaborations with members, particularly with people with lived experience of health inequities, and through strengthening our media work. We will also foster stronger relationships with individual parliamentarians, groups and committees in order to leverage parliamentary influence for UK action to improve health equity, including through our critical role coordinating across all relevant all-party parliamentary groups, APPGs. And then fourth approach we're going to take is the member and partner engagement. As a network organisation, all of our work and activities will continue to be underpinned by member and partner engagement. We will continue to do the majority of our work through working groups with members and providing other spaces for members to share learnings and collaborate together, as well as our membership changes. AfGH will foster an inclusive environment in the working groups, ensuring that new members are included and actively contributing into working groups. We'll be updating our ways of meeting, working, managing, decision-making and representation to ensure that these new collaborations and relationships are not tokenistic, and new members can meaningfully engage with and influence the network also. I'll now pass over to my colleague, Yuri.
Hello, everyone. Very nice to meet you all today. My name's Yuri. I'm the Senior Foundation Fundraiser for AfGH. I've got red brownish hair, which is tied back today, and a turquoise jumper. As you can probably tell from the presentations, we're really, really excited about our new strategy and would really like to welcome new members into the network who are keen to join us in this very important work. We particularly want to encourage organizations based in low and middle income countries, people with lived experience of health inequity, UK diaspora groups and regional health networks to let us know if you would be interested in joining the network through contacting AfGH on the details shown on the next slide. We'd also like to invite you to get involved through partnering with us on one of our strategic approaches and priorities, whether that be on tackling climate change and global health inequity, or in our work on the UK and health system strengthening. It would be really fantastic if you could also help us to spread the word about our new strategy through tagging us on Twitter or through connecting us with potential members, and also directing people onto our websites, our blogs and their testimonies from all of our diverse network members. If you'd like to find out more, please do come and say hello to us at one of our informal drop-in sessions. We will be sending out dates and invites and around those soon. And please ask questions to the team and engage us in conversation about how we can work together. And finally, if you're interested in financially supporting our work, then we'd be really thrilled to hear from you. You will see all of the relevant contacts on the screen now. So if you'd like to get in touch for a conversation or any questions, please do contact us using the email addresses listed here on this slide. I'm now going to hand over to Harry, who's going to do some final closing reflections. Thank you.
Thanks, Yuri. Can everyone hear me? Great. Yeah, hi, I'm Harry. I'm the Senior Parliamentary Advocacy Officer at Results UK, and I'm a member of the AfGH Steering Committee. I'm wearing a white t-shirt and have very straight brown hair. And I'm just here to wrap up the event, which has been really interesting, I think, for all of us here. I think particular thanks needs to go to the AfGH team, so Melanie, Melissa, and Yuri. They've been instrumental in guiding the process on this. And I think a particular thanks should go to Katie Husselby. She's been, I can't remember how long you've been coordinating the AfGH and managing and coordinating AfGH for, Katie, but you've been pretty instrumental and remarkable in the way that you've done it. And I think one thing this strategy really displays is the importance of ensuring all voices are heard and changing the language of global health, decolonizing, etc. And I think AfGH has been at the forefront of that. And like that's one really exciting thing that I've been sort of noticing since I've been involved in AfGH.
Sorry, I think Harry might have had a technical issue. Maybe I can jump in just to wrap up the session. Thanks, Harry, for those remarks, and thank you, Sarah, at the end. Oh, apologies. I think we're just getting the tech. Yep, I think I'm now on the screen. Great. Sorry, I think Harry's just had some issues there, so I'll wrap things up instead. Yeah, would completely reiterate Harry's thanks to the Action for Global Health team. It's been a lot of work gone into this strategy, hopefully, as you can see today. Also, like to take this opportunity to thank all of our fantastic speakers. Huge thanks to Kristine, Helena, Ellen, Melanie, Melissa, Yuri, for presenting the strategy today. I'd also just like to take this opportunity to thank on-call interpreters and to Mathilde and Belen for providing our French and Spanish translation today, and also to Russell and Bibi for providing the British Sign Language interpretation for the event as well. We're hugely excited, hopefully, as has come through today, to be launching the new strategy. And so I'd like to close just by thanking finally all of you for attending today's event. Just a reminder, the event has been recorded. We will be sharing around the webinar, so please do share with your colleagues, help us spread the word about our new strategy. And as I mentioned at the start, the strategy document is now available in English, and you can see the link in the chat box. And we'll also have translations in French, Spanish, Portuguese, and Arabic going up on our website later this week. A final reminder to please get in touch with us if you're interested in finding out more about the network and about our new strategy. And a final thank you to everyone for joining us today. And we will bring the webinar to a close there. Thanks, everyone. Enjoy the rest of your day.